Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health experts in OBGYN will answer your questions from bump to birth. Well, thank you so much for submitting your questions in advance. And the questions that you will hear me asking the providers are all submitted questions from you right when you registered for this webinar. Additionally, if you have any questions throughout the discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you will see an icon that says Q&A, and you can go ahead and type your question right there in the text box. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital university guidelines and privacy, we are unable to comment on specific cases. Likewise, if you are experiencing any symptoms that may require immediate medical attention, please consult a medical professional. Finally, don't worry, we've taken the liberty of muting everyone's line to eliminate any background noise, so feel free to move around and get comfortable. So with that, I would like to introduce our experts for the evening, starting with Dr. Shannon Davids, Dr. Rodney McLaren, Dr. Selena Davis, and certified nurse midwife, Melissa Peard. Well, thank you all for joining us this evening, and I'll give each of you a minute to say hello and share a little background about yourself. So Dr. Davids, let's go ahead and we'll start with you. And if you want to unmute yourself, always helpful.
That would help. I'm Dr. Shannon Davids. I'm a general OBGYN. I work at Thomas Jefferson in Center City. I see patients in our Center City office and our South Philadelphia office and deliver babies in Center City.
Thank you so much. All right, Dr. McLaren, let's go to you. How are you this evening?
I'm doing great. Thank you, Sarah. So I'm Dr. Rodney McLaren. I'm a maternal fetal medicine doctor that sees patients in the Center City campus. And I'm excited to be here and answer some questions.
We're excited as well. It'll be a great conversation. All right, Dr. Davis, you're next. Welcome.
Thank you. Good evening, everyone. I'm Selena Davis. I'm a generalist OBGYN. I practice at Einstein, Philadelphia, and I see patients at the Jenkintown location in the Einstein, Philadelphia main location. I have special interest in sexual function, obstetrics, and I work in the Pride Clinic for gender affirming and LGBTQIA care.
Okay, thank you so much. And finally, let's go to you, Melissa. Thank you so much for joining us this evening. How are you?
I'm great. Thank you for having me. My name is Melissa Peard, and I am the enterprise lead midwife. So I'm very, very happy to be here. I see patients at the Jefferson Northeast office and deliver babies at Abington. And we're really excited to be growing midwifery service throughout the enterprise and happy to be included this evening.
All right. Well, thank you, everyone. And without further ado, I think we'll get into our first submitted questions. And then a little later tonight, we'll take some live questions from the audience. So first question to start us out tonight, Dr. Davids, I'll go to you. Question number one from the audience: how can we optimize our body and overall health before becoming pregnant?
Well, I would say one of the first things to do is optimizing any medical conditions that you might have. So people who have high blood pressure or diabetes or seizure disorders, things like that, making sure that they're seeing whatever specialist helps them kind of manage those conditions and making sure that disease is as well controlled as it can be to kind of minimize the risks that might present in a pregnancy. Starting a prenatal vitamin is important as well. We typically recommend that people start a prenatal vitamin before conception, so at least 3 months before getting pregnant. Tracking the cycles is helpful so that we have some sense of a due date when people come in. And so keeping track of the first day of the last period is helpful. And then all the stuff that we know to stay healthy in general. So diet, exercise, sleep, stress reduction.
All right. Well, thank you so much. That was helpful. All right, question number 2, let's turn to Melissa. Specific question for you here. Prior to conception, how long should someone be off birth control for?
Yeah, that's a great question. And you know what, there's no, one specific, it's safe as long as it's been, X amount of time. People can take up to 6 months to return to having what was their cycle previously to being on birth control. So just kind of knowing if you're planning a pregnancy, some people aren't quite ready to get pregnant yet and want to go off of their hormonal birth control. And I always say, if you're not using contraception, that, you're welcoming a pregnancy. So some people will stop their hormonal birth control to, see what their cycles are without it. Just to piggyback on what Dr. David said, it's good to know when your last menstrual period was, but if you happen to, plenty of people come and they get pregnant, even before they get that first period, off of birth control, and we can always help you learn your due date through ultrasound, but you don't need to, worry about it clearing your system or harming the pregnancy in any way.
Okay, great. I think that's helpful information. Thank you. All right. And along those lines, Dr. Davis, are ovulation tests reliable? Are there any specific types or methods that you recommend for tracking ovulation?
Yeah, that's a good question. So ovulation is the release of the egg from the ovary, and a hormone called luteinizing hormone, or LH, which some people have heard about, rises about 36 to 48 hours to 40 hours before ovulation occurs. So there are lots of ways of measuring or kind of tracking ovulation. One of the ways that a lot of people use are the LH urine kits that you can get at the dollar store or at the pharmacy. There's also tracking basal body temperature, blood tests, and ultrasound to kind of check for ovulation. It's best to kind of talk to your provider what's the best method for you. The urine test kits are most commonly used. And so they're urine strips or urine like sticks that you kind of urinate on, and then they kind of check for that LH surge, that rise in the LH hormone. And then you should expect ovulation 12 to 24 hours after the urine test is positive. And so it's good to kind of use that while tracking your periods while you're trying to get pregnant. If it doesn't show that you're ovulating, it's good to check with your provider about ways to detect for ovulation, or if something is happening and you're not ovulating.
Okay, thank you. And a quick follow-up question for you, Dr. Davis. Are there ways that maybe you could help regulate your period to help with ovulation?
So there are lots of reasons why you would have an irregular period. So it's best to kind of talk to your provider about why your period is irregular and ways of kind of, evaluating that. And then once you talk to your provider, talking about ovulation as well.
Okay, thank you. All right, Dr. McLaren, let's go to you. For first question for you this evening. What are some things someone can do to prepare for pregnancy? If maybe you could speak a little bit about supplements, exercise, and even some things to avoid.
Sure, definitely. So starting an exercise routine before pregnancy is a great idea. You can, do routine like yoga, brisk walking, jogging, hiking, anything that you like to do. And it's something that you could definitely do throughout pregnancy. We actually recommend you do some kind of physical activity for at least 30 minutes a day, 5 days a week. And a couple of other important things you could do before pregnancy is make sure you're up to date on your vaccinations. COVID is a big one, flu when it's the season. And, last, this was already answered, but if you have any medical conditions, it's important to see your provider or have a preconception visit where we could go through the risk of certain medications, any certain advice that we could do to help lower the risk in pregnancy.
Okay, thank you so much. All right, Dr. Davids, let's turn to you. Talking about an important conversation here, miscarriages. Is there anything you can do to prepare your body when trying to conceive after a recent miscarriage?
Yeah, I mean, miscarriages happen in different ways. Sometimes people have a spontaneous miscarriage and it happens at home. Sometimes people just have a pregnancy that kind of stops growing and they need a D&C or they need to take medicine. But I would say the first thing is to make sure the miscarriage is complete. And so, if you have a D&C, we don't typically bring people back in for follow-up after that. But sometimes if it's happened at home or if you've taken medication, sometimes we'll see people back or do an ultrasound to make sure the miscarriage is complete. But I would say first, kind of making sure that resolved without complication. And after that, I think taking some time to process the grief, because that's very real. And then if people are feeling ready to conceive again, some are and some aren't. Sometimes you'll talk to couples and they're like, wow, I think we want to take a break for a little bit. And some couples want to try again. If people do want to try again, it's okay to try again after the next menstrual cycle. I mean, you have to wait until all the bleeding from a miscarriage is resolved first. And then we typically will tell people to wait for a period, because it does help to kind of date the subsequent pregnancy. We used to tell people to wait several months before conceiving again, but the newer research is showing that it's safe to conceive again. And if anything, the fertility rates might be a little bit higher. So we do tell people now there's no waiting period after a loss, and that they can go ahead and try again if that's what they want to do. But I do typically tell people wait for a period and then can try again. And if it's, the other thing is if it's a recurrent miscarriage, looking into that, one miscarriage is typically, kind of a random event, I would say, but people who have had 3 or 4 miscarriages, those people warrant a workup to see kind of what's going on there. And if there's something that we can do to intervene to help that not happen again.
Okay, thank you. And interesting to hear about that new research. So thanks for sharing that with us. Okay, Melissa, question for you. How do you prepare for a pregnancy a year after a myomectomy? And in fact, maybe you can start by telling us what a myomectomy is.
Yeah, sure. So a myomectomy is an operation that removes a non-cancerous tumor in the uterus called a fibroid. Fibroids are really very common. So this is a great question. Pardon me. And so I think the most important thing is preoperatively, your GYN surgeon should have discussed your family planning plans with you and given you an appropriate window to allow for the uterus to heal, making the pregnancy safe. So I think, most people know how long their surgeon did advise before becoming pregnant. If by chance you are not sure, or perhaps you've moved, you have found a new doctor, the best advice that I can give in this instance is to have your operative report and to have a preconception counseling visit with either a midwife or an OBGYN. If you have had a myomectomy before, while a midwife is a fine provider for you to speak to, you might actually benefit from having a consultation with an OBGYN because they are surgeons and would be able to guide you for your next steps. So if the provider that you saw who performed your myomectomy is going to be your pregnancy care provider, then you're great. I think a preconception visit for anyone, myomectomy or not, is a great idea. If they already are familiar with your surgical history and performed your surgery, then you're in great shape and they'll be able to guide you. If, like I said, perhaps you're in a new city, welcome. If you're new to Philly, any of us would be happy to see you, but please bring your operative report because it's important for us to know how the myomectomy was approached to give you the appropriate advice.
Okay, thank you so much. Very helpful information there. All right, Dr. Davis, we will turn to you from another question that we received. What are the first steps for attempting pregnancy in a same-sex marriage?
So there are lots of fertility options depending on the goals of the family or individual and what organs they have, if they want to carry pass on their genetic material. The baby, your provide what your goals is include intrauterine insemination, IVF, egg donation, sperm donation, a gestational carrier, adoption. And so kind of deciding what's best for you and your family is important, and then discussing that with your provider.
Okay, thank you so much. All right, Dr. McLaren, let's go to you. What is considered actively trying to conceive, and after how long is there a sign of maybe a potential problem?
Yeah, this is a great question. So there's no specific definition of what trying to conceive entails, because it varies from couple to couple. To be actively trying to conceive, the couple has to have regular unprotected course, which again will vary. But timing around the time of your ovulation, your cycle is key. In terms of how long before there's a potential sign, problem will depend on your age. So if you're younger than 35, after trying for 12 months and you haven't gotten pregnant, then that's the time you should see your provider. If you're 35 or older, then it's after 6 months.
Okay. All right, thank you. And just a quick follow-up question to that. Are there key signs of infertility? I think a big question is, when should someone seek fertility consultation and even fertility treatment?
Yeah, so other than the timing, I think one of the main key signs is how regular your periods are. If you have irregular periods, then that's something that you should evaluate and see a fertility doctor for.
Okay, thank you. All right, Dr. Davids, we'll go back to you. When is it too early to be looking for an OB/GYN? Can you seek out an OB before trying to conceive? So maybe you're already established with a provider that you like?
It's never too early. It's never too early. No, I think finding somebody that you like and that you kind of vibe with early is a great idea. I think, especially if you have specific goals or questions or things that you're looking for. But I see a lot of patients for preconception visits, and I love it because it gives us a chance to kind of answer a lot of the questions we're answering here, which come up. And then a lot of people wonder, like, well, what's going to happen once I get pregnant? They want to know kind of what will happen in the first couple of weeks, and you can kind of set them up so they have some expectation of what is to come. And I think people feel more comfortable having an established relationship before they get the positive test at home. They know somebody, they know who they're going to call, they know, okay, I'm going to be seen at 8 weeks. Okay, I'm going to have an ultrasound here. It's not like just a big question mark in their head. Like, they have some sense of what's to come. And then they know, like, if something's not right in the beginning, that they can contact somebody sooner, that they don't have to wait until their first visit. So I love a preconception visit. I think it's so smart. And sometimes you'll find a medicine somebody's on that they really shouldn't be on in pregnancy, and you can fix that then, rather than having angst once they're pregnant and they're worried that they expose the pregnancy to something. And so you can absolve a lot of those jitters by meeting with people beforehand. So I don't think it's too early before the pregnancy.
Okay, that's great to know. Yeah, taking away the fear of the unknown. All right. Let's go ahead to the next question. Melissa, a common question we've been receiving is, how do I choose an OB? Where can I go to research OB/GYNs and midwives to choose the right one for me?
Yeah, that's a very personal answer. I think the first place I would look is on the Jefferson website. There's it's like a kind of a turquoisey box that says find a provider. I always advise finding a provider that's close geographically. In the beginning of pregnancy, you come once a month, but towards the end of pregnancy, it's every 2 weeks and weekly. So you want to pick someone that's, geographically reasonable to you, and make sure that the, hospital in which they deliver, is also, geographically appropriate to you. So I think those would be some of the logistic things that people think about. While we are all one Jefferson, we do deliver at we all, meet our babies at different places. So it's very important that you feel comfortable going to the geographical place that you'll deliver. So that would be the thing that I would start with. Each hospital has its own model. Some of us have a laborist model. Some of us have a more private practice approach. And I think that, there's benefits to everything. And I think the most important thing is that you get a sense of safety. And the other important thing is that you may not know the provider who's going to be there on the day that you deliver. Labor happens at all times, but having providers that you feel comfortable sharing your preferences, and that your preferences are important to us, and you may for example, share your preferences with me, but deliver with one of my partners who you never met, but I'm going to do my best to communicate your preferences and talk to you about it. And we all work together as a big team. And so our goal is, we can promise two things, and that's kindness and safety. And that's very important to us to be able to provide to anybody.
Absolutely. Well, thank you. And thank you to all who have been submitting your live questions. We see them coming in, so we'll be getting to them in just a little bit, but we appreciate, this engaging discussion so far. Okay, now let's turn to Dr. Davis. Question for you, if you don't mind just going through some of the questions that we should be asking when talking to a potential provider.
So kind of like what was previously stated by Melissa, kind of like making sure the location of the office is important, the delivering hospital, if it's close to you, check for insurance coverage, and then access to the provider, or what are the hours for appointments? Are there early morning appointments or evening appointments? What's the on-call coverage like? What if you have a question in the middle of the night? Is there telehealth options? There are options on the patient portal. And then kind of for the provider themselves, like the certification or specialties of the provider, recommendations from family members or friends. If someone likes that provider and you feel comfortable with the person recommending the provider to you, and then most importantly, how you feel with the provider. So kind of talking to them. Do you feel like you're listened to? Do you feel like you can trust them? Are you able to speak freely? Do you vibe with them, like you said, Dr. Davis? And so it's important for your health, that you're able to be comfortable and ask questions. So it's important that you feel comfortable as well.
Okay, thank you. Yeah, paying attention to that vibe is important. All right, let's turn to Dr. McLaren. A more precautionary question for you. What precautions do we need to take during ovulation and the 2-week wait when someone might be pregnant, specifically regarding alcohol, caffeine, and cardio exercise?
So the precautions that you need to take during that 2-week window is to not drink any alcohol. Definitely continue taking your prenatal vitamins. Continue doing your exercise routine throughout. Regarding caffeine, there are potential theoretical risks. So I usually recommend to limit the amount of caffeine you drink, especially during this 2-week window. Because the evidence, there's no number or safe number of caffeine that you could drink before you have those effects. I just generally recommend limiting it.
Okay, thank you. All right, Dr. Davis, we'll turn to you. Big question for you. What should someone do when they first take an at-home pregnancy test and it's positive?
Yeah. So if somebody's planning a pregnancy and it's a positive test, you call the provider that you've established with or that you plan to see. And usually if you pee on a pregnancy test and if it's positive, you're typically what we call 4 weeks pregnant because you date it from the beginning of the period. And most practices will see you around 8 weeks. That's pretty typical that you set a first prenatal visit around 8 weeks. And so I always tell people, don't be surprised if when you get pregnant, they schedule you for a month out. That's okay. It's normal. But typically around 8 weeks, we'll bring people in, we'll do an ultrasound in the office. And, the vast majority of patients also get a formal ultrasound with MFM specialists like Dr. McLaren a little bit later in the first trimester. But at the first visit, we bring them in at 8 weeks. We do an ultrasound, we do an exam, we address symptoms, that kind of stuff. So that's the first thing to set up is that visit. If you already weren't taking vitamins, you'd start your vitamins. And then watching for anything that would warrant the earlier evaluation, significant cramping. A lot of people have kind of random cramps and stretching pains and gas pains and some of the glamorous stuff that comes with the first trimester, but true persistent cramping that worried somebody for miscarriage or bleeding, those sorts of things you'd want to call the office for sooner. And you would tell the person on the phone, it's not just a pregnancy visit, I need to be seen because there's something up. And then people will bring it in earlier. But really just establishing that first visit. And then, if you start to accumulate discomforts of pregnancy, which is not uncommon, if you're nauseous, if you're constipated, if you got the fatigue and all the things, just kind of jotting those down. My patients often bring a list, they bring their to-do list of questions or symptoms that they want addressed. So kind of just collecting all of that to bring to the first visit so you can make sure they're addressed, because a lot of it, no need to struggle through heartburn or constipation or anything. We can help with that. So just kind of formulating a list of things you'd want addressed at that first visit too is helpful.
Okay, great. Thank you for detailing that. Really helpful there. All right, Melissa, let's turn to you for something that might be a little bit concerning to some people. What happens if you get pregnant when taking medication that says you should avoid during pregnancy?
Sure, that's a great question. And I think the first thing that I would say is that you're not alone. 50% of pregnancies are unplanned or unexpected. So I think the first thing is just to give yourself a little grace and a little kindness. The second thing that I would say is there are a few category X medications, meaning that we have proven that we know are teratogenic and we really are worrisome. If you're on one of these medications, you have most likely been have had family planning discussed with you and ensure that you had a family planning method in place. If you do get pregnant on one of these medications, I think, again, having that pre-conception counseling visit or having been established with a midwife or an OBGYN provider or even a nurse practitioner in an office that you trust and can go and say, this is the situation that I'm in. And I think the best thing that we would do, and one of the great things about Jefferson is that, being a midwife, while we can see high-risk pregnancies in conjunction with our physician partners, even if you are a generalist and you have someone who needs a specialist, we can call an MFM like, Dr. McLaren, and we can get you hooked up with our bigger system and really kind of make sure that you get the testing that you may need and the consultations that you may need to put your mind at ease and to make the decisions that you need to make. So the first step would be just take a deep breath, show yourself some kindness and some grace, get on the phone, get seen, and we can, within our system, we can refer you to get the testing and next steps that you need to be able to walk you through your plans.
Okay, thank you so much. All right, we'll take just a few more submitted questions and then turn to our live questions for the rest of the evening. But first, Dr. Davis, I'll turn to you for one more submitted question. What should someone be on the lookout for in early pregnancy?
Yeah, so in early pregnancy, your body's kind of just adjusting to being pregnant. So for first-time parents, it can be a big change. Even if you've been pregnant before, every pregnancy can be different. So sometimes you can have some nausea, vomiting. There are lots of ways to kind of help with that. Eating smaller meals.
I think you might be cutting out for a
Trying
minute.
different fruits or cold things. If you're not able to tolerate food.
Okay. Dr. Davis, we might turn to our next question. I think you might be just having a little internet trouble. So we'll skip you for right now, but come back to you. All right. Dr. McLaren, we'll go to you for the next question. What genetic testing is standard or available during pregnancy?
That's a big question. So I'll try not to take too much time. So there are a few standard and routine genetic tests that we could do during pregnancy. I'd say in general, there's one for the mom and there's one for the baby. So the one for the mom is actually something that you could actually do before pregnancy. It's called carrier screening. So this blood test is looking to see if you're a carrier for a genetic disease. So in general, everyone has 2 copies of genes. Some of us may have one gene that does not work and one that does. As long as you have one good gene, then you're not going to show any symptoms. But when you have a baby, you pass one of those genes to the baby, and then the father passes the other gene to the baby. So if you have a bad gene, we generally recommend looking at the father to get his blood test to make sure he does not have the same bad gene, because then there's a potential that the baby could get, both bad genes. And we can figure all this out, before pregnancy. During pregnancy, the blood test for the baby, we look for common genetic issues like Down syndromes, some common trisomies. We typically start with doing a blood test. It's important to note that the blood tests we're taking from mom, so it's not going to be 100% accurate. It kind of just tells us the baby's high risk for having something or low risk, but it doesn't tell us that we have something or doesn't have something. But we do have tests where we could sample the placenta or the fluid around baby. And we generally recommend that, if the blood test is abnormal. And you could, skip the blood test and go straight to the, where we take the sample from the baby if you don't want the blood test.
Okay, thank you so much. All right, let's talk about diet for a minute. Melissa, I'll go to you. What aren't you allowed to eat during pregnancy? And the big question, I know Dr. McLaren touched on this a little bit earlier, but can you drink coffee?
That was my biggest question too. I'm with you. So the most, you want to stay away from foods very high in mercury. This is usually pretty easy for folks like king mackerel and swordfish, not a whole lot of that around Philly. So tuna steak, you want to stay away from. If you really, really, really have a craving for like a tuna salad sandwich, every now and again is fine. You want to make sure that your food is really, really well cooked. Everything is really well washed. I always recommend, eating the rainbow, lots of fruits and vegetables and whole foods, lean meats and proteins. You want to, obviously giving into a pregnancy craving every now and again is, what we're here for, but You want to try to stay away from foods very high in sugar content, very processed foods. And that's just kind of general, treat your body really, really well. As far as, caffeine, like Dr. McLaren had mentioned before, there's no, I can't sit here and say 2 cups of coffee it's totally safe. There's a great article that I always refer folks to. It's by an MFM, Nathaniel Fox. And if you just Google Nathaniel Fox do's and don'ts of pregnancy, I keep actually a PDF of this on my phone, and it's written to be read by folks just like you, to answer questions just like this, and in a very evidence-based way. So it presents you with the research, and then, what is the practical real life. And so if you, and he kind of recommends if you drink a cup of coffee, a day, you're from what we can see, you are probably fine. But obviously, we don't recommend going overboard. Just everything in moderation. You don't want to do too much. But if, you drink coffee and you're really not feeling well, and maybe a cup of decaf makes you feel a little better, I'm sure you're going to do just fine.
So can you confirm, is decaf then okay to have 1 or 2 cups of?
I feel pretty reasonable saying that, if you have a cup of decaf a day, that you're probably doing just fine. I think that's a reasonable answer. Yeah, enjoy it. I certainly did.
Okay, that sounds good. Sounds like everything in moderation.
Yes.
Yeah. Okay. Well, thank you so much. All right, Dr. Davis, I see that you're back. Let's see if your internet is working for us this time. What exercises? Oh, can you hear us?
Yeah.
You're good. Okay, perfect. I'll go ahead. What exercises are safe to do before pregnancy that can continue during pregnancy? And how much walking can someone do in their last trimester?
I'm sorry about the internet situation. Yeah, that's a good question. So in general, exercise is healthy in all aspects of your life, and it's important during pregnancy. A lot of times, people just stop doing exercise because they're scared, but it's important to, talk to your provider if you're having any questions. Usually in uncomplicated pregnancies, exercise is safe to do. And sometimes you need to make some modifications, and your provider can help you with those. Walking, cycling, dancing, resistance exercises, stretches are all safe. In general, you want to avoid dehydration, heated, laying flat on your back, anything that kind of increases the risk of falling. And then walking, it depends on how much you were walking before and how you're feeling when you're walking. In general, walking is very safe.
Okay, great. Good to hear walking is safe. So we can add that to the list. Awesome. All right. With that, I think we've been getting a lot of questions in the chat. So let's dive into some of the live questions now, if you're all ready for it. Okay, so question number 1, let's get to it. Melissa, this one is for you. Will having an abortion hurt my chances of getting pregnant? So if you can answer that, for anyone else, feel free to chime in. But yeah, first question of the night.
Yeah, so this is a very, very common question. And I do come from a family planning background, and this is probably the most common question when someone is considering, having an abortion. And it gives me great pleasure to provide you all the reassurance in the world that no, that abortion, if everything went normally and safely, will not, affect your future fertility. It's a very good question, and I'm sure you're not the only person in the chat room with that question. So thank you for asking.
Yes, thank you so much. All right, let's go to our next question. This one for Dr. Davis. Again, though, whoever wants to chime in, feel free. This is an open discussion. Will my period change and my ovulation change once I'm off birth control?
So so on birth control, you may be having regular periods because of the birth control. So more of like a withdrawal bleed. And you're generally, if you're taking the birth control as directed, not ovulating if it's a birth control pill. So after taking the birth control, it's important to kind of monitor what your periods are like. They may go back to how your periods were prior to being on the birth control. They may be a little bit different if some time has passed. So monitoring what your periods are like and then talking to your provider if they're irregular.
Okay, thank you so much. All right, Dr. McLaren, a question for you. What are chemical pregnancies and miscarriages? If you can speak a little bit about that.
Yes, so I guess chemical pregnancies are, where your test is positive, but the pregnancy doesn't form, and a lot of times you may have miscarriage after that. And it's important then to follow up with your provider to ensure that the pregnancies is going in the right location.
Thank you. All right, Dr. Davids, question from the audience. I heard that it can take approximately 6 months after removal of a Paragard IUD to realistically get pregnant. Is that true?
Yes and no. Different birth controls take a different amount of time to quote unquote wear off. Things like an IUD or the implant in your arm, typically fertility like reverses quickly, so you take it out and then you should be fertile. Stopping birth control pills, you might wait like up to 3 months to get a period back, but typically within the first 3 months you get a period. The one contraceptive that has a delay to the return of your fertility is Depo-Provera, the shot. It can take up to a year to get your fertility back after that. So the sort of time from when you stop a contraceptive until your fertility returns to its baseline varies with what contraceptive you had, but really the Depo is the only one with a prolonged delay in that return. That being said, though, like Dr. McLaren said, normal fertility is up to a year, and 85% of couples are going to conceive in a year, and 15% won't, and those are the 15% that we give a diagnosis of infertility to, that we offer to help. But it really can take a full year. And I'll show patients a curve. When you look at 0 to 12 months, it's like this, so a lot of people kind of conceive in the beginning, fewer people at the beginning, fewer people at the end, and a lot in the middle. So having an IUD out and then it taking 6 months to conceive would be very much in the range of normal. Your fertility from having a Paragard or a copper IUD out, your fertility came back right away. And then it's going to take up to a year to conceive if you have normal fertility. So very much in the range of normal.
Okay, I think that's good to hear. Thank you. All right, Dr. McLaren, I know we talked a little bit about genetic testing earlier, but do you recommend counseling or testing for unknown genetic markers that the parents might carry? And if so, what is the process for doing so?
Yeah, so I definitely recommend, what's called carrier screening. And the main process is it's something that can be ordered during your preconception visits. And we could also, schedule you to talk to one of our genetic counselors who will, go through your family history, and they may, pick up on certain things that, that you may not know about, that can help with the testing as well.
Okay, thank you so much. All right. Question for you, Dr. Davis. What are the risks of getting pregnant while obese, or how long should you wait to conceive if on prescribed weight loss medication?
So We, recommend that you are trying to get as healthy as possible prior to pregnancy. So kind of working on healthy lifestyle choices with diet and exercise prior to pregnancy is really important. For weight loss medications, it's important to discuss with your provider prior to trying to conceive to see if they're safe during pregnancy. It depends on what medication the person is on. There are some risks with obesity during pregnancy. There's increased risk of diabetes in the pregnancy. There's increased risk of preeclampsia, increased risk of needing a C-section. So lots of ways that your provider the person can kind of decrease these risks while, discussing with the provider.
Okay, thank you. All right, Melissa, turning to you, a more specific question here. Are all women expected to give birth on their backs in the hospital? If you could talk. Okay, there we go.
I'm happy to elaborate. When you are in labor and you begin to push, I think if you do not have an epidural, you're kind of telling us what you're feeling, obviously. If you do have an epidural, there are, times in which we may start pushing in, lithotomy position, which is kind of like the traditional, what you see everyone, in the movies giving birth. But, babies have to navigate pelvises. This is a dyad, and there are many different positions that we can help you best have your pelvis help your baby navigate for your birth. For some people, that could be side lying or even like closed knee approach, using a peanut ball in labor. So are there moments when kind of pushing or giving birth in, lithotomy position are beneficial? And there are. And if you're in a situation where that happens to be the position that your baby is passing through your pelvis the best, we'll give you that feedback. But we're a team, and we follow your lead, and we give you feedback about the position of your baby in that moment. And but no, we don't tell you what to do. We give you information of how to help you have a healthy birth.
I think that's an important reminder that we're a team. So thank you for calling that out there. Okay, Dr. McLaren, we'll turn to you for another live question. If there is a history of gestational diabetes in your family, what should you consider before or during pregnancy?
So you should, consider, seeing your provider. There are a few tests to test if you have, diabetes. That's something you could do prior to pregnancy. During pregnancy, we would test you early, just to make sure that it's something that's not brewing, and then we would test you again before 28 between 24 and 28 weeks.
Okay, thank you. All right, Melissa, we'll come back to you for another question here. Sort of two questions, so if you need me to repeat, feel free to ask. But how important is your partner's smoke cessation when planning a pregnancy? If your partner is currently a smoker, how does it affect conception and sperm motility? And what recommendations do you have for a partner's food, alcohol, exercise while trying to conceive?
Sure. So, obviously secondhand smoke and smoke in the household, does have an effect on everyone in the household. And can, have an effect on the pregnancy. So if your partner is smoking and you're hoping to plan a pregnancy, then, having your partner see their provider to help with smoking cessation, I think would be the first step, it certainly can affect sperm motility. And so, when you start to begin to plan a pregnancy or welcome a pregnancy into your home, obviously you have to sort of look at your life in a holistic, big picture way and start thinking about making, bigger, healthier choices. And also, like I said, 50% of pregnancies are unplanned sort of at baseline. And if you know that smoking in general isn't great for your health. So, just kind of taking those steps for smoking cessation is, always recommended. And then I'm so sorry, the second part of that question again, please.
Yeah, of course. Just talking a little bit about a partner's food, alcohol, or exercise while trying to conceive.
Yeah, sure. So again, yes. So looking at, the whole family in a holistic way, the health, it may not, directly affect your partner's fertility in general, but you're having this child to be with this child for a long time. And you want to get your, sometimes this is a big wake up call for folks like, oh, I've got to, take some steps and also, make some better choices for my health. So just, whether or not it has a direct effect on fertility is one discussion, but it certainly has a direct effect on your health and your well-being for your whole family.
Absolutely. Thank you so much, Melissa. Okay, Dr. Davids, we'll turn to you. What additional considerations should women of advanced maternal age make prior to conceiving?
Very common question. As a member of that club, I'll tell you that, I guess one thing would be just kind of thinking about fertility in general, kind of thinking of it from like getting pregnant, the pregnancy itself, and the delivery. As we mentioned before, fertility considerations are different in people who are advanced maternal age. And that's those of us who would be 35 or older at the time of delivery. So you could be 34 and then deliver at 35, you're considered advanced maternal age. But I think that, just keeping in mind that their fertility may be decreased compared to somebody who's 19 or 20. And that's the reason that we intervene sooner to help people become pregnant at 6 months rather than 12 for people who are 35 and older. So not to say that they have reached infertility at the 6 month mark, but just kind of knowing that the ovaries and the eggs are maybe not as hot as they were 20 years before, we sort of help those people sooner. So I think acknowledging that and then kind of keeping track of how long you've been trying and how's it going and that kind of thing. And then seeking out help sooner than folks who are younger. So I would say at the 6 month mark, if you're not pregnant, asking for an evaluation, some help if you want. Now, some patients don't want that. Some people I talk to and I say, at the 6 month mark, I'd offer to intervene and they say no thanks, but no thanks. And that's also okay, but just sort of at least knowing that offer's there. During the pregnancy, there's an increased risk of pregnancy loss, of genetic issues. And so first trimester can be a little stressful, I think, for folks. And, same thing there. Some people want that genetic testing. Some people want genetic testing for reassurance or to make pregnancy decisions. And some people don't. And so it's not required. If you say like, gosh, it's just going to stress me out, like also it's not a required thing. And so it's really individualized, but certainly kind of figuring out like, would that information be helpful to me or not? And doing genetic testing if it's helpful. Certainly making sure you have an ultrasound at like the 12 to 13 mark, to kind of 12 to 13 week mark to make sure that the pregnancy is progressing. And then during the pregnancy, like a little extra testing, we'll typically do a growth ultrasound in the third trimester, make sure baby's growing well. We'll do some test of baby well-being in the third trimester, kind of closer to delivery, which we don't do in younger patients unless they have another condition. But it's just kind of putting monitors on your belly, watching the baby's heart rate on a graph, like an EKG kind of. And you're just making sure that the baby's thriving and doing well in there. And so we do start that. So there is a little extra testing we'll often talk about the benefits of being delivered by the due date. It's not required, but we'll talk about the sort of special benefits of being delivered by your due date that are probably more so beneficial in people over 35 than somebody who's 19, 20. So I think those are the specifics, but most people who are 35 and older and are able to conceive go on to have healthy, normal pregnancies.
All right. And I'm sure that's reassuring for many listening. So thank you. All right, Dr. Davis, we will turn to you now. How long does implantation bleeding last? A little bit more of a specific question for you.
Yeah, so that depends on the person. Usually it's like spotting, like light bleeding. You might see it when you wipe, or not significantly heavy bleeding, not necessarily needing to use a panty liner or a pad. But with any bleeding in early pregnancy, I would recommend talking to your provider to kind of figure out what's happening, just to make sure everything's okay.
Okay, thank you. All right. Actually, I'm going to give you one more question before I let you go here. A follow-up question for you. Are there concerns with certain medications during pregnancy, such as antidepressants, migraine medications, and even what about ibuprofen or Tylenol? And if you want to answer this, or another doc, Dr. Davis, if you want to chime in, whatever works. Oh, I think you might be on mute, Dr. Davis.
Is the question for me? I'm sorry. Yeah.
Either one. Dr. Davis, if you want to chime in as well, I can repeat the question.
Oh, sure. I mean, I'm happy to answer the first part. Certain meds, are not great in pregnancy. And that's why the preconception visit's so helpful, because, stopping those before the pregnancy even starts is helpful. Most of them, if they're being prescribed, if you're on, a seizure medicine by your neurologist, or if you're on a blood pressure medicine by your primary, it's helpful to tell them you might be conceiving, a year in advance, 6 months in advance, whatever, because they'll often transition you off of a medicine that you shouldn't be on in pregnancy and transition you to something that you could be on. So I always tell people, if you're seeing a specialist for your diabetes, blood pressure, seizures, whatever, mental health, let them know that you are planning on conceiving, so that they have that time to transition you, and then make sure that whatever disease process they're treating is still well managed. But an example would be something yes, the SSRIs are common antidepressants, and those are safe in pregnancy. There's one in particular, Paxil, that we don't typically use. It can lead to some heart issues in babies. So if you were on that one, you might switch to a different one. But we tell people there are some small risks with using an SSRI in pregnancy. Sometimes the babies will come out a little jittery or irritable, but that can be managed easily. And when you sort of look at the whole picture of somebody who could have their mental health managed and could really focus on their wellness during the pregnancy, and especially the postpartum period, which is its own animal, but setting themselves up for success by already kind of feeling like their mood is stable and having medication on board, will do a world of wonders for them, for the baby. And so that little risk of baby irritability when they come out is so outweighed by the benefit to the whole family of the birthing person feeling well, that the vast majority of our patients stay on those medications.
Okay, thank you. And a quick follow-up there, just regarding ibuprofen or Tylenol. Is that something that's safe to take during pregnancy?
So I could take this one. So ibuprofen is, we generally recommend avoiding ibuprofen during pregnancy. There are certain times where we may use it in a certain point in pregnancy, but we generally recommend, Tylenol to take during pregnancy.
Okay, that's great to know. All right. Well, I know we're at the top of the hour, but we'll just take a few more questions because we've been receiving a ton of amazing questions. So thank you all for this great discussion. All right, Dr. McLaren, I'm going to turn to you for another question here. Does stress, something that obviously we all experience, does stress affect your ability to conceive?
That's a great question. Stress it's part of your well-being and everything. I don't know if we have any good evidence that points one way or the other, but it theoretically can have issues with conceive, but that's a great question though.
Yeah. An interesting one for sure, but something obviously we all experience. So always fun. Okay. Dr. Davis, we will turn back to you for a minute. Any tips to alleviate morning or all day sickness? I know this is probably a popular question many are wondering.
Very popular question. I know a lot of people are miserable with morning sickness or nausea and vomiting in pregnancy. There are lots of things that are helpful. A lot of times people like to try eating small meals throughout the day instead of, what some people typically had 3 big meals throughout the day, having like small meals throughout the day, maybe having some crackers next to the bed, even before you wake up, having, cold things, having banana, fruit, things like that, avoiding anything that is causing nausea. If you smell something you don't like it, you can stay away from it. But if those types of things don't help, there are medications that are helpful, and you can talk to your provider and we're happy to prescribe them. There are a lot of very safe medications that help with nausea and vomiting. A lot of people like to try, ginger and some natural things as well. But there are lots of options that are helpful. So don't suffer through it.
Don't suffer. That's right. Okay. Thank you. All right, Melissa, we'll turn to you. We have a great question. I know that I'm wondering this myself. So what is the difference between a midwife and an OBGYN? Do you have to choose one or the other, or can you have both? And what is a doula? And do they work with my provider? Can you bring a doula to appointments to help with a birth plan and be active during the hospital delivery? So another big question for you.
Okay. Sarah, I'm going to ask you to please keep me on track. So the difference between a midwife and a physician, I will start there. So I am a midwife. I'm an advanced practice nurse. Not all midwives were nurses first. But at Jefferson, most of us took the track that we became an RN and then got a master's degree specializing in care of a birthing person and gender specific care for people with cervixes and uteruses. So we can diagnose and prescribe and treat. Midwives have a very specific scope of practice. We specialize in a normal pregnancy. That what makes Jefferson so very unique and wonderful is that, and this kind of bridges into the next answer to the question, is that at Jefferson, we can consult with our physician, OBGYN partners. We can consult with our maternal fetal medicine partners and really give a holistic approach to viewing your pregnancy. And you and your baby benefit most from, just like you have benefited tonight from hearing lots of different perspectives. An OBGYN is someone who is a medical doctor who has gone to medical school and who is also a surgeon, and midwives are not surgeons.
Okay.
So do you have to pick one or the other? At Jefferson, luckily you don't most of the time. So you can, some people would want to choose one or the other because, and many times it has more to do with kind of the vibe you get from a person more than the letters at the end of their name or their specialty. And I would absolutely listen to that. We're very lucky here that we all approach people giving birth with the same, from the same kind of point of view. We may have a different, we may travel on a different road a little bit, but we have the same destination. We want you to be heard. We want you to feel safe. There may be times that your pregnancy risks out of midwifery care. So sometimes someone might start with a midwife, have wanted to, really desired midwifery care, but maybe their pregnancy had a complication along the way, and a midwife can co-manage with our physician partners. And then there are times that we have to refer, meaning that the pregnancy becomes too high risk for a midwife to care for the pregnancy. But we can certainly still stay involved, from a social aspect, just, support. So what is a doula? A doula is not a medical provider. A doula is someone that you choose to be a support person. We know that, this is someone who may support you on labor and delivery. And many of the Jefferson locations do welcome doulas on labor and delivery. I know where I am at Addington, they do have to show their credentials. So a doula is someone that goes through a certification to learn about different ways to support you in labor. There's also something called a postpartum doula, which is someone that can come to your home after you have the baby and help support with, that transitional time after you leave the hospital and when you're back at home. I think this work, this is wonderful, especially, we mentioned folks on medication for their mental health. This would definitely be something that I would look into to help preventative measures for postpartum depression. We know that a doula support is something that is, benefits folks immensely. But, some people choose to hire a doula. But from our perspective, we view a doula in the same way that we would view someone who brought their mother, their sister, their closest girlfriend. There are trained doulas that provide a wealth of knowledge, but a doula ultimately can be anyone who loves you. And we would never tell you that you couldn't have someone that loves you with you during your birth.
Okay, well,
what did I miss? I feel like I missed something somewhere.
I'm pretty sure you got it all. So thank you so much. And I think that was a great last live audience question for the evening. So we appreciate it. But I do have one final question for you all before we close out tonight. And that's just, what are your goals for everyone listening on this webinar? What would you like our viewers to take away from tonight? So Dr. McLaren, let's start with you.
Sure. I guess the big takeaway from this webinar is that there are many things that you could start doing now before your pregnancy, taking prenatal vitamins, exercise, everything that we talked about here. And that, we're always here to, help you, navigate that as well. And yeah.
Thank you. Perfect. Thank you so much for your time this evening. All right, Dr. Davids, we'll go to you. Any big goals you would like our viewers to take away from tonight?
I think establishing with somebody, a care provider, and we've talked about all different kinds and the pros and cons of them. And, but I think just establishing with somebody that you're comfortable with kind of to hold you through this whole process. And so that it feels guided and not just like you're asking random questions, but it should feel like an organized process that someone's walking you through, and just somebody who you feel like is like hearing your questions, acknowledging you, takes your symptoms seriously, takes your questions seriously, advocates for you. Like if you've got something you really want, you feel like they have a plan of like how they're going to help you achieve that. But I think if you have that, then all the rest of it kind of falls into place. So I think it's just really important to find somebody you connect with.
Okay, perfect. Thank you so much. And Melissa, any big takeaways for our viewers tonight?
Yeah, so I think one of the things that I love about being here at Jefferson is that, you know, our team here can really take folks from the lowest possible risk to the highest possible risk pregnancy and really provide you with a lot of different points of view. We work, you know, all as a team, and our most important thing is to provide you with a space that you feel safe, that you feel heard, and that, you know, no matter, you know, pregnancy, you know, sometimes can start very low risk and change even throughout that time. And that no matter what happens along your journey, that we'll be able to, you know, help you navigate that, you know, with our team. And, you know, none of us take care of you alone. And so just kind of remember that there's lots of different folks with their eyes and their point of view on you, and you don't have to choose just one. We all kind of work together.
Okay, thank you. And last but not least, Dr. Davis, any takeaways from tonight? Oh, I think you might be on mute.
Okay. We're here just to partner with you, and we want you to find a provider that you're comfortable with, and to kind of help you along in your pregnancy journey. And so you feel comfortable and free to ask questions and feel supported.
Okay, thank you so much. All right, well, thank you, Dr. Davids, Dr. McLaren, Dr. Davis, and Melissa, all for your time this evening. Certainly a ton of great information was shared. And thank you all so much for attending and submitting your wonderful questions. I know I learned a lot, so thank you. We will be posting an event survey, so you can let us know your thoughts. Any other specialties you would like to hear from? Your feedback will bring more virtual events like this to you, the patients. And if you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. And be sure to visit jeffersonhealth.org to make an appointment. Stay up to date on upcoming events and webinars just like this one. Please also visit thehealthnexus.org for more health content, patient stories, research, innovation, and much more. You can also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to planning for pregnancy to robotic surgery. A recording of this event will also be sent to you next week so you can rewatch at your convenience. And finally, here is a map of all of our Jefferson Health OB/GYN locations. If there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Thank you so much and have a wonderful evening. Bye.